Rami, you are muted.
Good evening, everyone. We are lucky today to have Professor Ahmed Fayed. He will present to us a very hot topic about pregnancy-related acute kidney injury. Also, we have today Professor Yasser Abdulhamid and Professor Rasha Samir as a modulator. So I will leave the floor to Professor Yasser Abdulhamid to present Dr. Ahmed Fayed.
Bismillah ar-Rahman ar-Rahim. Welcome everyone in this meeting of Egyptian Society of Nephrology and Transplantation CME chapter meetings. And I am pleasure today to have two of my friends co-chairing and speaking in this session. The first is Professor Rasha Samir, who will co-chair this session with me. Professor Rasha is Associate Professor of Nephrology and Medicine, Mansoura University. And she is one of the founders and the main player in Mansoura Obstetric Nephrology Clinic. Professor Rasha is a member of ISN Women in Nephrology and Afran Women in Nephrology working groups. And she is known in Egypt, in Africa, and even worldwide by her great interest in the subject of women in nephrology and obstetric nephrology in general. Because of all of this, she will, and because of her publication and expert in this field, she will co-chair this session with me, and we are expecting a very interesting session full of informations and discussions. Coming to the speaker today, our speaker today, who is my friend and one of the very eminent professors of speakers of Egyptian Society of Nephrology and Transplantation and Cairo University, and one of the interested in topic of critical care nephrology, Professor Ahmed Fayed, who is Associate Professor of Nephrology and Medicine, Cairo University. Professor Fayed is my dear friend and young brother, and he is joining me and in our journey in critical care nephrology initiation and all through these years in Cairo University. He is one of the head of acute kidney injury team in Cairo University and one of the staff members and one of the main staff members in nephrology and internal medicine ICU in Cairo University. Professor Ahmed has many publications in the field of nephrology and in the field, especially in the field of acute kidney injury, and is interested in this topic of pregnancy-associated acute kidney injury and critical care nephrology in general. Before I leave the floor to Professor Rasha to co-chair this session, I would like to thank Dr. Rami Abu Bakr, who is our coordinator today, who is MRCP and Egyptian Fellowship member of and MD of in the University and Egyptian Fellowship of Ministry of Health Egypt, and MRCP, and I think he's a fellow of DIMPRA. I'm right?
Yeah.
DIMPRA Royal College. So we are honored today to have him as coordinator and one of the staff of this session, managing this session together, and because of all of his work in CME chapter of Egyptian Society of Nephrology and Transplantation. We will show informations in case-based discussions, case by case, and we'll come to you for discussion after each case. So please, Professor Rasha, start.
You are muted, Dr. Rasha.
Dr. Rasha, you are muted.
If I can mute.
Professor.
Yes, thank you. It's working now. Thank you so much, Dr. Yasser, for the invitation and for the kind introduction. So humbled and honored to be part of this webinar. I hope we're presenting interesting cases Dr. Ahmed is going to present, and the discussion is going to be fruitful and beneficial for everyone. Thank you. Dr. Ahmed?
Yes, Dr. Rasha.
Are you ready to start?
Okay. Thanks for my dear colleague, Professor Yasser Abdel Hamid, Professor of Internal Medicine and Critical Care Nephrology in Qasr Al Ain University, and Dr. Rasha Samir, my dear friend, Professor of Nephrology in Mansoura University. Today we'll discuss topics about the pregnancy-related acute kidney injury. Do we know what to do on the case-based discussion? First, we'll introduce a short introduction and also we'll give short hint about the pregnancy-related acute kidney injury spectrum of the disease, and we'll try to present 4 cases from our units. First, must be known that there is the anatomical and the physiological changes that occurs during the pregnancy due to the effect of the pregnancy hormone. The anatomical change including the increase in the kidney size about 1 centimeter and the dilatation of the collecting system, mainly on the right, more on the left. And this have the clinical impactions, leads to the difficulty to diagnose the true obstruction and leads to increase the rates of the pyelonephritis from the asymptomatic bacteriuria. Also, there is the physiological changes, including that glomerular hemodynamics, vasodilatations, and increase in the renal blood flow and GFR. There is a problem.
We can hear you well, Dr.
Yes, okay. And also the vasodilatations and increase in the renal blood flow and GFR, and also the tubular function due to the alternation in the tubular reabsorption of the protein, glucose, and the amino acids, and also the uric acid, and the electrolyte balance. There is increase in the total body sodium, total body potassium, and decrease in the set point of the thirst and the ADH release with expansion of the plasma volume. And this leads to the decrease in the blood pressure and potentially allowing for less medication and the decrease in the serum creatinine and mildly increase in the urine protein. When we talk about the kidney and the placenta, both are the sophisticated vascularized machine, and they filter the blood and they divide the compartment and into two compartments. And the pregnancy is considered as an precious occasion to diagnose the chronic kidney disease. From the kidney to the placenta, chronic kidney disease can induce placental dysfunction, with increase the risk of the preterm delivery and the hypertensive disorder of the pregnancy and the preeclampsia. And also, from the placenta to the kidney, preeclampsia can induce a permanent damage can introduce the permanent damage in the kidney, and the preeclampsia can lead to permanent damage via the acute kidney injury and also tubular damage and also the podocytopathy with podocyte loss. When we talk about the pregnancy-related kidney injury, it is considered as a high or global health problem and associated with the higher rates of risk and also with the higher risk of post-maternal and fetal outcome, with morbidity and mortality. When talking about the risk factor, which is very important, including the old age and also the previous history of the preeclampsia and the presence of the comorbidity, especially the diabetes. There is increased the rate of the pregnancy-related acute kidney injury due to the higher rates of the detection and also the higher rates of delivery in the hospital and the higher rates of overall comorbidities due to the advanced maternal age and increase in the high-risk pregnancy. As any acute kidney injury, the pregnancy-related kidney injury may be the pre-renal, post-renal, or renal. Pre-renal including the hemorrhage, hypovolemia, and the sepsis, and the congestive heart failure. The hypovolemia usually from the hyperemesis gravidarum, and the intrinsic renal as the ATN, thrombotic microangiopathy and HELLP syndrome, preeclampsia spectrum, and acute fatty liver of the pregnancy, GN, and acute interstitial nephritis, which occurs due to the medication exposure. And the post-renal include mechanical obstruction, neoplasm, uretropelvic obstruction from the pregnancy, or mechanical obstruction which may occur post-surgical. And this figure shows that the time frame for the disorders of the acute kidney injury. And when you look here in the late second and the third trimester, the preeclampsia spectrum and the thrombotic microangiopathy, and also the non-steroidal anti-inflammatory drug uses occur, and the GN occurs all through from the first to the third trimester. And the urinary tract infection is common in the second and the third trimester. And again, according to the physiological and the anatomical changes, there is no standard criteria to define the pregnancy-related acute kidney injury. The very important question before we are going to the cases is to biopsy or not to biopsy during pregnancy. The decision of the kidney biopsy is made on the gestational age, available treatment option, and the viability of the pregnancy. And the kidney biopsy should be performed only when the diagnosis of AKI can facilitate the management and improve the maternal and the fetal outcome. It is safe to do the biopsy in the first and second trimester, and there the minimal risk of complication with gestational age of the 25 weeks. As the pregnancy reaches the third trimester, the very important was much to delay this biopsy and focused on the early delivery, and then biopsy in the postpartum period if needed later on. And this is the management. It is the challenging because it is a multidisciplinary team, because it is associated with the risk of the two lives, both mothers and the baby, and should be performed in the form of the multidisciplinary team. And the fetal assessment is very important, including the serial fetal ultrasound for early detection of fetal growth restriction, monthly in the first trimester, in alternate week in second trimester, and weekly in the third trimester. And as the general measurements for the any AKI, intravenous hydration to correct the volume depletion, and use of the alkali therapy for metabolic acidosis, and also blood transfusion for anemia, and the potassium binder for hyperkalemia, and the loop diuretic. Loop diuretic, as general, it is contraindicated during the pregnancy to avoid the placental hypoperfusion, only used in the volume overloaded patient. And the antibiotic, according to the urinary tract infection, and the analgesic, and even stent or nephrostomy may be needed with the obstructive AKI. And the renal replacement therapy must be initiated when indicated, and there is a rapid deterioration of the kidney function. And again, this is the spectrum, which is with the specific treatment for each disease. We will not find, but we'll discuss this during go to the special cases that will we discuss. But the very important issues is the preeclampsia. When to indicate to deliver the woman with the preeclampsia, first, inability to control the blood pressure, deterioration of the glomerular filtration rate, and the neurological abnormalities that is occur, such as eclampsia, headaches with accompanying with the clonus, hyperreflexia, or repeated visual scotoma, worsening of the thrombocytopenia, increase in the liver transaminase, failure of the growth retardation, or affections in the cardiac topography of the fetus with reversed or absent end-systolic flow. This is the clear indication for delivery of the woman with the preeclampsia. And the thrombotic plasma exchange, which is an important issue that will be discussed. Thrombotic microangiopathy is the main indication, but not all the thrombotic microangiopathy needs the plasma exchange. In the placental cases, placental causes, including preeclampsia, HELLP syndrome, and acute fatty liver of pregnancy, delivery here is curative, and the thrombotic plasma exchange, it is not indicated. But in the non-placental cause, like the TTP, atypical HUS, secondary to the antiphospholipid antibody or catastrophic antiphospholipid syndrome, or certain virus infection inducing thrombotic microangiopathy, delivery is not curative, and here the thrombotic microangiopathy is must to be indicated. The most common indication to doing plasma exchange during pregnancy is the thrombotic microangiopathy, with the indication is the one with the evidence is 1A. To remove the ADAMT S13O antibody with replacing deficient ADAMT S13 protease activity, and remove the autoantibody or defective complement regulator with replacement of the exogenous complement factor, and also the removal of the cytokine that damages the endothelium. This is the rationale for the TMA in pregnancy. And the frequency, we do it daily until the platelet count to more than 5,000 and the LDH normal for at least 2 consecutive days. And then you can taper or abrupt discontinuation of the plasma exchange according to your experience with the patients, according to the circumstances. And this is different from one patient to the another. And the replacement fluid recommended to be the plasma or albumin, and may be preferred to be cryoprecipitated in the presence of the TTP. Immunosuppression during pregnancy, generally for glomerulonephritis, steroid and immunosuppressants like azathioprine and the calcineurin inhibitor, cyclosporin and tacrolimus during pregnancy can be used. But very important for you, all cases is case by case, because it must to weigh the risk versus benefits for each patient. Again, you must to be clear message, mycophenolate, sirolimus, and cyclophosphamide are contraindicated in pregnancy. In refractory cases of TTP, rituximab should be given in use, but you must to be cautioned that because it may cause fetal B cell depletion, especially used in the 3rd trimester. And the oclizumab is an option for the treatment of the atypical HUS in the resistant case. Now we will go to the core of the lecture, which is the case-based discussion. I will introduce the 4 cases. The first case with it will produce the 20 years old prime gravida presented to us at Qasr Al Aini Hospital with history of intrauterine fetal death before the admission at the 38 weeks of gestation. And the patient complaining from high grade of fever for 2 days before delivery, followed by the smoky urine, oliguria, and the breathlessness. At the time of the referral, the patient complicated with the leaking per vagina for 1 day and the absent fetal heart sound. The patient also complains from left upper quadrant pain with the sharp and localized just below the costal margin for 10 days. Following vaginal delivery, she was referred to the nephrology department in the view of renal dysfunction and shortness of breath. The patient is conscious, irritable, with the blood pressure about 180/78 millimeter mercury and the pulse rate 100/18 per minute, with the saturation 98 on the room air, and the patient was febrile. Pallor with pitting edema were present. In the cardiovascular system, there is the soft S1 and there is the pansystolic murmur characteristic of the mitral regurg radiating to the axilla and also to the back. And the patient was found to have an advanced AKI with serum creatinine 7.4, potassium 5.8, and the bicarbonate 12. And the urine analysis shows the albumin 4+ with the plenty of the RBCs, mostly dysmorphic, and the 24 urinary protein was 2.8 grams per day. TLC count was marked leukocytosis, 32,000, with the serum procalcitonin is also high, indicating the active bacterial infection. And the blood culture which done come out to be sterile, that is to be done repeatedly. Normal complement with negative immune profile, ANA, and the other serological marker. And we do the chest radiography. The chest radiography shows a pulmonary picture suggestive of pulmonary edema. And the ultrasound shows that splenomegaly with wedge-shaped splenic infarction measuring 3.5 centimeter to 2.3 centimeter, as in say by the yellow arrow here. We do the echocardiography for the murmur that occurs, and it shows that the large mobile mass, 15 millimeter by 9 millimeter, with the anterior mitral leaflet, and the moderate mitral regurg with global hypokinesia of the left ventricle with ejection fraction 30%. And she was initially managed as a case with hyperkalemia and the volume overload and the infection with empirical antibiotic, including vancomycin and clindamycin. And she received 13 sessions of hemodialysis over the period of the 6 weeks of the hospital stay. And the first question for the floor, renal biopsy to do or not to do? We do the renal biopsy. We saw due to the persistent renal dysfunction and the activity in the urine, despite the improvement of the marker of the infection. And this is the renal biopsy. In the renal biopsy, we find 9 glomeruli with cellular crescent, as you see, without tuft necrosis on the light microscopy, with interstitial fibrosis and tubular atrophy EFTA less than 10%. And the immunofluorescence using then serum complement 3, mesangial granular deposition, and the immunofluorescence of the IgG, IgM, and C1q and the kappa and lambda were negative. Now, we are diagnostic criteria for infective endocarditis related glomerulonephritis. This entity that is raised in these patients, and to diagnose this entity with infective endocarditis related glomerulonephritis, at least 3 of the following must to be present. With the presence of infectious disease before or at the onset of the GM, hypocomplementemia and the endocapillary proliferation and the exudative glomerulonephritis on light microscopy or renal biopsy, C3 dominant deposition in immunofluorescence, and the presence of the hump-like subepithelial deposition on electron microscopy. And as you see, the 3 out of 4 because we don't do the electron microscopy. And we started on patient empirical steroid in the view of the cellular crescent and the non-improving renal function under cover of the antibiotic. And the patient administered the 3 doses of the pulses methylprednisolone for the 3 days, followed by the oral steroid in the form of the cellular crescent and no renal recovery. There is gradually the urine cleared of its cola colored, and over the next 3 weeks, and the urine albumin reached nil, RBC stooped to 3, and the 24-hour urinary protein, this is occurs after 3 weeks, become 100 milligram, with urine output increased to 2.5 liters per day. And after the 10 weeks of follow-up, the serum creatinine improved to 1.3, and the size of the vegetation reduced to 8 millimeter to 4 millimeter at last follow-up, which is done after 3 months. And my take-home message from this infective endocarditis associated crescentic GN in the late pregnancy with normal complement level and the rapidly progressive glomerulonephritis presentation is relatively a rare presentation. And in our patient also, don't forget, the culture is repeatedly negative. We continued on the empirical antibiotic and the pulsisol and methylprednisolone, followed by the oral prednisolone in the form of the crescentic GM and the protracted renal function. But to be clear, this crescentic rapidly progressive glomerulonephritis, it needs an issue of antiproliferative, but we don't give any cyclophosphamide for these patients because the risk of the vegetation, and this was the great discussion in our department. And again, it is difficult, whatever this patient improvement with the renal function is present due to the control of infection or the administration of the steroid.
Thank you, Professor Ahmed, for this first case. And your comment, Professor Rasha, please, if you have. Professor Rasha.
You can mute yourself.
I'm sorry, I was muted. Thank you, Dr. Ahmed, for the interesting case and for the successful outcome at the end of the case. I think infections leading to crescentic GN or rapidly progressive GN, in particular infective endocarditis, has been known for long. But during pregnancy, it's not a common case or a rare case. I'd like to start by the question sent by the floor to the chat box. So I see that's asking about the source of infective endocarditis.
Okay, the source of infective endocarditis, it's most probably this is an septic abortion that is occurs for the not a septic abortion due to the infection, because the patient is having the fever which is developed 20 days before the admissions to our units, and she presented to us with the pains in the left hypochondrium with the splenic infarction. The infective endocarditis, it usually present with infarction. It usually take about 10 to 3 weeks to be presented by this presentation, and I think it is presented during pregnancy, but we don't have the clear cardiac history from these patients to be present. And again, the examinations of the patients, the clinical examination shows the typical anterior leaflet mitral regurg with the presence of the pansystolic murmur that is radiating to the axilla and to the back. So we don't have, if these patients have also previous, because as you know, the Professor Rasha, the rheumatic heart disease, especially in the rural area in Egypt, we can't be, it is maybe accidentally discovered, and it maybe have the rheumatic heart disease, and it develops disease vegetations over this, because the common presentations over the mitral area, mitral valve, it usually present with the rheumatic heart disease.
Another question.
I'm just commenting that the case actually presented with intrauterine fetal death, I think 2 days before the presentation, and the patient had a vaginal discharge with fever, which all coincides with what Dr. Ahmed said, that the patient had maybe a presentation of puerperal sepsis or intrauterine infection at time of presentation. We have a second question regarding the use of steroid in such case. Is it
risk of
yes.
Yeah.
Risk of.
As you said, Dr. Rasha, the short introduction that I gave is in the immunosuppression as total in the pregnancy, it is to be the risk and benefit. And this patient is delivered. And here the risk, the use of the steroids here in the setting of the sepsis, we give the steroids, not empirically, we give the steroids after we see the renal biopsy with the crescentic GM. And the second decision, it is to do the cyclophosphamide or not, because according to the guidelines, you must to do the dual, not the only the steroids for the proliferative lesion and rapidly progressive glomerular nephritis. But due to the large size of the masses that is present and the vegetation, we give only the steroids and don't give the other immunosuppression. And as Dr. Yasser said, because it is a great discussion in our department, we give it risk and the benefit.
Okay, another question, Dr. Ahmed, about did she fulfill the full criteria from Dr. Ahmed Amara, full criteria of infective endocarditis, or maybe a thrombus, just a thrombus?
No. The full criteria is present, the full dox criteria. The only is the sterile negative. The only against the major criteria is the absence of the positive culture. But we do also the culture for the fungi and they become sterile. And this is according to the presence of the repeated culture that is negatively. But as Dr. Rasha say, this patient is presenting with the intrauterine infection, intrauterine fetal death, and also the source of infection that is the present before the delivery, in addition to the cardiac insult. So we considered with this huge, large vegetation mass is considered as a case of infective endocarditis.
Another question, which is the core of the dilemma, is about from Dr. Ahmed Amara, indication of steroids. If it is infective endocarditis, it will recover only by treating the primary lesion. But steroids, intake of steroids was questionable here. And I think it was because of crescents. And this
yes, because of the crescent. Because of the crescent.
I also want to take opinion of Dr. Rasha in this issue, please, especially.
So I agree that the case had 100% crescent. In the biopsy, as Dr. Ahmed said, all the glomeruli shown in the biopsy had crescent. So in this case, with the presentation of rapidly progressive GN, it's considerable to consider immune suppression with umbrella or under umbrella of antibiotics.
Which was done. Did you echo? Echo, Ahmed.
Yes, yes, we do the echo.
Okay.
We do the echo.
So there is a question I cannot understand. MR goes with DDD. So please rewrite the question and we'll answer after the second case. And if you can understand these abbreviations, MR goes with DDD. I don't know. Okay, please rewrite your question, reformulate your questions to be without abbreviations. And we can go to the second case, Professor Rasha.
It's okay.
Okay.
Okay, the second case here, we will present a rare presentation of the common cause for the pregnancy-related acute kidney injury. This is the 32 years old female lady, gravida 2 para 1. That is presented with the intrauterine pregnancy at the age of the 12 weeks of gestation. And she was initially admitted to the inpatient with the psychiatric units. 7 months after delivery of her first child due to the new onset of psychosis and starvation ketosis. And her past medical history included hypothyroidism, inflammatory bowel disease with undetermined colitis, it's not differentiated ulcerative or the Crohn's, and anemia of the chronic disease with no prior psychiatric illness. And her psychiatric symptoms don't improve after initial inpatient treatment with olanzapine and mirtazapine and the haloperidol. And she continued to deteriorate with the ongoing refusal to eat and the 10 kilogram weight loss, which represented 20% of her weight at the presentation. And her current pregnancy was also complicated by the ultrasound with diagnosis of multiple fetal anomaly at the 17 and the 20 weeks of gestation with the double outlet of the right ventricle and the transformation of the great arteries. At the 20 weeks of gestation, she was started lithium, which is considered as the first-line antipsychotic medication during pregnancy. And at the 26 weeks of gestation, she develops the symptoms of the upper respiratory tract infection and significantly decreasing the oral intake of the fluid. And her dehydrations leads to the volume depletion and the impaired renal clearance of lithium, and the lithium toxicity with serum lithium level 3.9 millimole with the normal is 0.8 to 1.2 millimole. Also, she developed respiratory failure due to the aspiration pneumonia, and according to that, she admitted to our ICU, and she was intubated and mechanically ventilated. And all culture were collected before the antibiotic therapy, and they had already been initiated, and she received norepinephrine with the piperacillin tazobactam due to the presumed septic shock. And she started for dialysis due to the lithium-induced acute kidney injury, and she received the 2 sessions of the SLED sessions of the hemodialysis, and 1 week after the ICU admission, her fever resolved, and her YBCs downtrended from 24.1 to 19.1, and the lithium decreased to the less than 0.1 millimole, and her serum creatinine improved from 2.5 milligram per deciliter to 0.6 milligram per deciliter, and again, all culture ultimately come back to us negative for gross. At 27 weeks of gestation, vasopressor was discontinued, and we observed that the patient developed multiple mild range blood pressure more than 4 hours apart, and the intermittent severe range of the blood pressure, which is persistent for about 2 weeks after the vasopressor was discontinued. On the same day, when her blood pressure became elevated, she has developed an elevated liver function test and rapidly increased in the liver function test, especially in the ALT and the AST over the next 24 hours, and the liver ultrasounds revealed only the hepatomegaly with otherwise normal appearing liver. And due to the concern of the medication side effect as an underlying etiology of the elevated liver function, first the piperacillin tazobactam was discontinued, and her sedative were changing from propofol to the dexamethasone. The dexamethasone in the market is known as the Presidex. And after this medication change, her AST is slightly downtrended to the 30/23, and the ALT is uptrended, not decreasing. 24 hours later, the liver function again subsequently increased, and the AST is 506 and the ALT is 510, elevated LDH 600 unit, and elevated albumin creatinine ratio to 2.8 gram, and the uptrending of the platelet count up to 400 per cubic millimeter. She had normal serum creatinine now, serum glucose level, coagulation profile, and her peripheral blood don't show any evidence of hemolysis. We search for the fragmented RPCs, and there is no evidence of the fragmentation. And also during extubations from the mechanical ventilation, we noted that the rhythmic jerking of her bilateral upper extremities. It was initially concerning this as a seizure activity versus agitation. However, she was subsequently had the normal EEG. And due to the overall of this, with the presence of the laboratory criteria and the presence of the rhythmic jerking on her bilateral upper extremities, the clinical picture concerning the preeclampsia with the severe feature is present. And she received the 2 doses according to the 12 milligram of dexamethasone intramuscular for fetal lung maturity, intravenous magnesium sulfate for seizure and for seizure prophylaxis, and rapidly we go to underwent the cesarean section at the 27 weeks of gestation. This is according to the indication of the delivery in the preeclampsia. And the differential diagnosis here for the patient with elevated blood pressure and the elevated liver function test is preeclampsia with the severe feature at the top, hemolysis with elevated liver enzyme and low platelet count, HELP syndrome, and the patients don't have hemolysis and don't have the low platelet count. Thrombotic thrombocytopenic purpura, not in our case. Atypical hemolytic uremic syndrome, not in our case. Acute fatty liver of the pregnancy. Ischemic hepatitis shock and shock liver, which is okay, but the liver function test is increasing 20 times up to the normal. And the peak occur with the 24-hour and the drop to the half by the 27 to 48, 78 hour and normalize by 7 to 14 days, and not in our case. Also, there is a syndrome called the propofol infusion syndrome. The liver function test elevation is extremely high. It has the hepatomegaly, metabolic acidosis, rhabdomyolysis, and the bradyarrhythmia, and not in our case. And the last one is the piperacillin tazobactam that is induced the liver function. It increased in the 6 to 15% of the patient. This is the differential diagnosis that we put, and in the top, as you see, preeclampsia with the severe feature. On postpartum day 1, the liver function downtrend rapidly, and on the postpartum day 2, her blood pressure returned to the normal with AST and ALT is still 96. And at her outpatient postpartum checkup for 1 month after delivery, she continued to have normal blood pressure with AST and ALT is normal. And when to go to the neonatal outcome, it is becomes a small for gestational age with birth weight 840 grams, and the postnatal image confirming the multiple cardiac anomaly, and he died and passed away after the 36 days. And we presented this case as I felt this is the rare presentation of the common causes of the acute kidney injury related problem during pregnancy, because this is highlights how the difficulty in diagnosis preeclampsia, especially in the critically ill patient, in this patient with the presence of the multiple medical picture in which the end organ damage can potentially be attributed due to the other problem or the medication side effect, as we see in the differential diagnosis.
Thank you, Professor Ahmed. Professor Rasha.
Thank you so much, Dr. Ahmed, for this interesting case too. A very rare case of lithium intoxication during pregnancy. And we know that lithium toxicity may be indication for hemodialysis in severe cases where there is severe neurological toxicity with seizures and coma, or neurological, or renal insufficiency with lithium levels more than 4 or 5, where the normal range, as you said, ranges between 0.6 to 1. The presentation of the patient at the Late part with hypertension in the second half of pregnancy or hypertension after 20 weeks with evidence of organ involvement, mainly liver involvement, and kidney involvement was predicting as well. Raised suspicion of preeclampsia as one of the differential diagnoses, and as you included drug-induced injury as well. But the hypertension in particular proposes more likely preeclampsia. Severe preeclampsia itself, or let us say preeclampsia itself is not an indication for termination, but severe preeclampsia with refractory hypertension with severe or progressive organ dysfunction, kidney dysfunction, or progressive other organ disease or development of eclampsia with seizure represent the maternal indications of termination. On the other hand, we have also fatal indications for termination of pregnancy in women with refractory preeclampsia, which mainly include the placental Doppler evidence of placental ischemia or reversed umbilical flow, or babies with impaired, or let's say evidence of fetal distress with impaired fetal cardiotocography. Let's see if there is any questions on the case.
One question from Dr. Farhan is asking about if acute fatty liver of pregnancy. It looks like acute fatty liver of pregnancy.
The acute fatty liver of pregnancy, Dr. Yasser, is associated with markedly elevation of the liver function test, increasing up to 10 to 20 times percent of the normal. This is number one. And also, the other issue, it will be the high levels of the ammonia level. And the ammonia level we do in these patients, the ammonia levels is normal.
Okay, and we have lithium. Okay, Dr. Ahmed Amara. Challenging case. Thanks, Dr. Ahmed. Why therapeutic abortion not advised? From Dr. Ghada Sobhi.
Yes, we do here. We do in this case in our colleagues, Dr. Mahmoud Suleiman and Dr. Ahmed Rashwan, which is the professors in the high-risk department of the pregnancy in Qasr Al-Aini. They discussing with the patients to do the termination for these patients due to the presence of the multiple anomalies, and they decide to continue. And as you know, in our policy, we don't rush for the abortion. They ask for the abortions, for the therapeutic abortions, due to the three conditions: the multiple anomalies of the fetus, and the general condition of the patients with the loss of the 20% of hair body weight, and also the associated comorbidities that is the presence of hair, but they decided to continue on pregnancy.
Okay, another question.
Continue the patient or the obstetricians?
No, not the obstetricians, the patients and the family.
Oh, yeah.
The obstetrician can decide to do the abortion, but the family asking, not decided, and they decided to continue.
Okay, comment from on the chat about that ischemic hepatitis and ischemic acute kidney injury and acute fatty liver, acute liver insufficiency may be behind elevation of serum lithium in this patient.
Yes, this Dr. Yasser, as you remember, we put it in our differential diagnosis in the floor with the ischemic hepatitis that is occurred due to the marked hypoperfusion. But against is the two issues. The first issue is the lithium is returning to the normal after the 2 slit sessions of the hemodialysis. This is the first, but it may induce. And the second issue, the ischemic hepatitis, is associated with the curve with increasing up to 10 to 20-fold of the upper limit of normal of the liver function, which is not in our case, and returning to the normal after 4 to 7, as I discussed in the case.
Okay, Professor Riyad Saeed is with us. Professor Riyad, can you comment, please, on the previous two cases? Unmute yourself, Professor Riyad.
Hello.
Hello, Professor Riyad.
Hello.
Welcome. Long time.
I think, Allah yakhallik. And I think, concerning the current case, I think it's really still acute fatty liver is a major consideration. But as we hear that the ammonia level was really normal, that's one thing. But the lithium toxicity, usually it's well known, and I think the current treatment with SLID was the appropriate therapeutic intervention, which is really you require long hours of hemodialysis, not really short hours of dialysis to remove the maximum amount of the lithium. That's usually the case. And I think ultimately this patient should be really terminated because initially, not really to wait until 27 week of gestation to start having seizure activity and all this kind of situation. In spite, we advise, and it's quite risky. The baby is really malformed. There is malformation in the baby, and we know that there is some abnormalities. So why? What's the wisdom? If that was explained to the family in complete situation, and I think they would agree about this, especially she has one baby to start with. Okay, and the mother's life was really risky. She's depressed. She has weight loss, 20% of her weight. She's not eating. She's been intubated and then start having convulsions. So really, it was, in my view, termination should be started as early as possible. Concerning the first case, I came in late, but really it's a very interesting one. The only thing I have, serum complements was reported to be normal. And we know that in post-infectious, at least, we should have at least low C3. That's really my two comments.
Thank you.
Thanks, Dr. Riyad, for your comment. The first, we do the SLID session because the patient is in the septic shock and she was hemodynamically unstable on the maximum doses of the norepinephrine at the presentation in the ICU.
I think that's perfect. This is really perfect approach. Really, I'm with that.
Yes.
It was the appropriate approach. Yes.
Yes, Dr. Riyad. And the second one, we are us in the ICU and in the nephrology department, all of us, in addition to the obstetrician, we are decided to terminate this baby due to the multiple anomalies that is present. What we are facing for the family, they resist to continue. He refused totally by all.
Yeah.
And the other issue,
explanation, Professor.
Yes, this is the explanation that is we do, and they tried many times before, even before developing the preeclampsia and during the lithium toxicity. And the other issue, Dr. for regarding the first case, we repeated the complement system C3 and C4 twicely, and they are normal.
Okay, Professor Rasha, thank you, Professor Riyad. Can we move to the third case?
I think Dr. Amara wants to comment. Dr. Ahmed Amara. So, okay, let's move to the third case.
Okay, the third case we will present today will present the case of 31 years old woman, gravida 3-para-2, presented at the 28 weeks of gestation, complaining of epigastric pain, worsening of bilateral lower limb edema, and the blurred vision. Physical examination revealed the high blood pressure, 180/110 millimeter mercury, bilateral lower limb edema, and the brisk reflex +4. Blood investigation shows a low platelet count and the high uric acid, 24-hour urinary protein 6 grams per 24 hours, in keeping with the severe preeclampsia. And the patient was started intravenous magnesium sulfate, labetalol, and was giving the 2 doses of the 12 milligram dexamethasone intramuscular, and the baby was delivered with an emergency cesarean section at the 28 weeks of gestation. And the patient received 1 dose of the amoxicillin intravenous, was started with 40 milligram per day on enoxaparin subcutaneous. Day 3 postpartum. The patient developed severely reduced visual acuity, abdominal pain, headache, and started spiking temperature up to 39.4 degrees centigrade. On examination, the patient found to have an abdominal tenderness in the right upper quadrant with Murphy's sign positive. And also the ophthalmologist shows that the bilateral oxidative retinal detachment. And the blood test shows that leukocytosis with the platelet count dropped to less than 50, and the blood hemoglobin level dropped to 8.3, normochromic with anisocytic erythrocytes. Activated partial thromboplastin time increased to 1.6 and the prothrombin time to the 14.7 seconds. His renal function deteriorated from 0.7 to 2.8 milligram. Ultrasound show a calculus cholecystitis, and the CT of the abdomen shows that mild ureterohydronephrosis with enhancing of the ureteric wall, suspicious of the bilateral pyelonephritis, and also there is the evidence of the bilateral bibasal consolidation and the suspected liver abscess. MRI done shows that the very small liver abscess, which are not amenable to drainage. Transthoracic echo reveals that poor left ventricular ejection fraction of 43%, and also the pericardial effusion. And now we are dealing with the case with the low ejection fraction, in addition to the sepsis that is the present. So that the first of issue we must to do, if the evidence of cardiomyopathy or evidence of pericarditis or evidence of ischemic affection. We do the cardiac MRI, and this cardiac MRI, and thanks for Dr. Abdullah Al-Agha, which is a professor of cardiology that gave me the pictures of this MRI and commented on it, shows that the myopericarditis and the peripartum cardiomyopathy with global left ventricular wall hypokinesia. And we do the MRI brain, shows that the multiple ischemic foci in both cerebral hemisphere, as seen in this image. Urine and the blood culture and the band culture is negative. Broad spectrum antibiotic in the form of 2 anti-pseudomonas with the piperacillin tazobactam 4.5 grams 3 times daily and levofloxacin 400 milligrams were given, was started to cover the pulmonary and the abdominal sepsis. Enoxaparin dose was reduced from 40 to the 20 due to the low platelet count, and the patient then transferred to our ICU for close monitoring. After 4 days in the ICU in this regimen, the headache, abdominal pain improved, and the fever settled. The blood pressure was controlled by only carvedilol 3.25, half dose of the 6.5 twice daily, and nifedipine 20 milligrams 3 times daily. After 7 days of the broad spectrum antibiotic, the patient started to spiking a temperature again and repeated left-sided pleuritic chest pain. On examination, the patient at this time, the temperature is 38.8 with pulse rate 110/15 and oxygen saturation 93 on the room air, and then there is no infectious source was identified. We suspected for the pulmonary embolism. CT pulmonary angiography revealed that left lower lobe pulmonary embolism and the intrasplenic vessel thrombosis. At this point, the patient was found to have positive anticardiolipin antibody, which is withdraw this from the patient at the admission to the ICU, and the positive anti-beta-2 glycoprotein antibody and the positive lupus anticoagulant. Histology of the placenta of the delivery shows a placental infarction, ANA. ANA profile anti-double strand DNA are negative. And we are dealing for the diagnosis of the CAPS, catastrophic antiphospholipid antibody syndrome, in the form of the presence of the multi-organ involvement and also the histology that is proven of the splenic or the placental infarction. This is our treatment plan. Broad spectrum antibiotic and the pulse steroid. Yes, we give a pulse steroid given 3 daily 1 gram intravenous methylprednisolone, followed by the prednisolone 60 milligram per day. And here's the issue for anticoagulation. We give 1 milligram per kilogram 2 times daily for the enoxaparin, and the aspirin 75 milligram per day. And the issues here for the plasma exchange with the presence of the multiple sepsis, or do the IVIG, which is considered to be an immunomodulating agent. We choose the IVIG. We give the 4 days of 0.5 gram per kilogram per day. And the therapeutic plasma exchange, it is one of the gold line of the treatment for CAPS to remove the antiphospholipid antibody TNF alpha complement system. But the evidence is one, with the evidence is the 2C. We do it daily until the clinical response and the replacement solution is plasma alone or in combination with albumin. But here, the market sepsis, that is the presence and the small liver abscess that we retracted to the plasma exchange and they give the patient the IVIG. Our outcomes, there is the clinical improvement was noted within few days. The patient was initiated on the long-term warfarin, and the patient was discharged at home for 4 weeks, and the platelet count and renal function improved to the normal level. Visual acuity improved to significantly, and the fundus examinations become normal, except only from the few area of retinal pigmentation, which is the normal sequelae for the exudative detachment that is the present. And the prednisolone was tapered slowly over the 4 months, and the repeated antiphospholipid 6 weeks later remained positive, and the echocardiography 8 months later for the peripartum cardiomyopathy shows that improvement of the left ventricular systolic function, and the ejection fraction become 55%. And the baby here with the neonatal outcome is discharged from our neonatal pediatric ICU in Abu Rish after 10 weeks with normal growth and development. Our take-home message for the catastrophic antiphospholipid antibody syndrome, which is the rare but relatively and the potentially life-threatening form of antiphospholipid, with the presence of multiple organ thrombosis that is present in our case, affecting at least 3 organs, and the histological confirmation of the small vessel occlusion that is present with the placental infarction, and also in at least 1 organ or tissue. And the CAPS present with non-specific symptoms, which may mimic the other conditions such as sepsis, infective endocarditis, or the vasculitis, and the other auto-inflammatory conditions. In fact, the triple therapy consisting of combination of anticoagulation, high-dose glucocorticoid, plasma exchange, and or IVIG has been proposed as a gold standard of the treatment. And recently, there is the new modalities have been emerged in the treatment of the refractory CAPS, not in the primary CAPS, including the rituximab and also the eculizumab.
Thank you, Professor Ahmed.
Thank you so much, Professor Ahmed, for the comprehensive presentation of the case. Yeah, I agree that the case had fulfilled the 4 criteria of catastrophic antiphospholipid syndrome, with involvement of more than 3 organs occurring simultaneously or within less than a week, and with a histologic confirmation done on the placenta with vascular occlusion, and the lab confirmation with a positive antiphospholipid lab profile. Fortunately, the patient responded to the standard therapy with steroids, anticoagulation, and IVIG favored because of sepsis on plasma exchange. And as you just presenting in the last slide, in refractory cases, we can resort to other immune suppressive, such as rituximab, eculizumab, and others. Let us see if there is any comments or questions on this case.
Antibiotic is not indicated here.
No, Dr. Yasser, antibiotic is very important, and we give the 2, as you remember, we give the 2 anti-pseudomonas, we give the piperacillin tazobactam in addition to the levofloxacin. Antibiotic is the first line of the treatment due to the presence of the intra-abdominal sepsis.
The comment is antibiotic is not indicated here. There is no abscesses, and it is multiple infarcts, not abscesses. All culture sensitivities were negative.
No, but we confirmed this. The abscess, we are not depending on the ultrasound and not depending on the CT. We do the MRI, and the MRI for the liver abscess, it had to do if we can drain or not to drain. So it is the characteristic abscess.
And culture
and also
sensitivity.
the procalcitonin is high. The procalcitonin is high is with the bacterial infection.
And regarding culture sensitivity, many infections we meet usually with negative culture, but there is infection, and there is sometimes passes to sepsis and septic shock with negative culture.
Yeah, I think based on the suspicion of multiple liver abscesses or presence of infection, it's wise to prescribe antibiotic or give antibiotic for the patient in a matter of cost-benefit relationship.
Okay.
Yes, Dr. Rasha, as we say, all cases with the pregnancy-related acute kidney injury and all cases in the ICU with the sepsis-related acute kidney injury, we do the risk versus benefit.
Yes,
دكتور
I
أحمد
would
عمارة
like
اتفضل.
to.
اتفضل يا دكتور رشا.
I just want to say I'd like to congratulate you for the good outcomes for these very challenging cases, Dr. Ahmed.
Thanks, Dr. Rasha. Thanks.
دكتور أحمد عمارة اتفضل.
Assalamu alaikum. Thank you, Dr. Yasser. Thank you, Dr. Ahmed Fayed, for the very nice cases. Thanks, Dr. Raja. I just may add practically in this case, as you know, when we request test for antiphospholipid, it may take 3 to 4 days to get the result. I think if I am managing this patient, I may manage it as TTB in the second presentation after fever subsided and platelets continue to be low with multiple thrombotic events. I think she can fulfill the criteria of TTB if we apply the plasmic score even without Adamantine 13 level. I can manage this empirically by plasma exchange, and I can change my mind after the result of antiphospholipid antibodies, as you mentioned. I need to hear your opinion about that.
Yes, thanks, Dr. Amara, for your comment. But we see for the TTB, to diagnose the TTB and start rapidly for the plasma exchange, the platelet count must to be less than 30. Here it is 50 nearly. And also the presence of hemolysis, which is very important, including the reticulocytic counts to be greater than the 2.5%. And this is not in our case, that is the present. And also the elevations, evidence of hemolysis with the indirect bilirubin greater than the 2 milligram, which is not present here. And also the main corpuscular volume to be less than the 9% flow liter, which is not also in our case. So that, yes, Dr. Amara, this is the one of the priority of the to be the both the thrombotic microangiopathy, including the TTB in one of the differential diagnosis of our case. But the absence of this only with the platelet counts that is the present here, and also the presence of multiple abscesses, that is retracted our decisions to do this, and both the catastrophic antiphospholipid antibody syndrome.
Thank you.
Yeah, thank you.
Comment that of the choice of IVIG that plasma exchange increases risk of infection in this septic patient.
Dr. Yasser, yes, Dr. Yasser, the plasma exchange and the IVIG, the gold standard, as I hear these in this slide, it's the high glucocorticoid plasma exchange, or maybe or IVIG. This is the gold standard according to the guideline. But the IVIG, it is not an immunosuppressing medication. It is an immunomodulating condition, and it is to be the ideal also in the sepsis. It will be help us in the sepsis also, not that is the presence with the high procalcitonin, as I see in spite of the presence of the multiple cultures that is the present. So that the plasma exchange is retracted here, but we do use the IVIG for these reasons.
Okay, thank you. Please, the last session, the last case.
Yes, okay. And the last case. This is the 35-year-old woman, born and living in Giza, married with 3 offspring. The youngest is 6 years old, gravida 4, para 3, experienced pre-eclampsia in each of her 3 previous pregnancies, with rather good fate for mother and baby, apart from the 4th time. In the 4th pregnancy, she developed her usual pre-eclampsia in the 32 weeks, which was complicated by intrauterine fetal death, concealed accidental hemorrhage, and the retroplacental hematoma, as well as renal failure with creatinine 10 milligram and anuria. And the hemoglobin 6.8, and the MCV here is 83, and the platelet is 93, and TLC is 17. Consequently, she was admitted and terminated by the cesarean section, and the patients received a total of 8 to 10 packed RBCs and the 12 units of the platelets. Admitted to our ICU, where she received the 4 sessions of hemodialysis upon the impaired kidney function and the complete anuria. On examination, the blood pressure is 160/90 with pulse 110, temperature 37, respiratory rate 36 per minute, and lax abdomen. CRB is high, 97, and all PT activity, BTT, PC, and INR are normal. Blood film and schistocyte is 1.95%. LDH is the 3000 and reticulocytic counts 40%. Combs test is negative. Total bilirubin is 2.1. ALT is 44, AST 39, and virology is negative. And ANA is negative. Serum complement is normal. Ultrasound bilateral enlarged kidney and bilateral parenchymatous renal disease, moderate ascites and mild hepatomegaly. Transvaginal ultrasound is normal. And here, what is the clinical diagnosis and the differential diagnosis? We are dealing with here a case, as my colleague, Dr. Ahmed Amara say, with the peripartum AKI, thrombocytopenia, with the non-immune hemolytic anemia. First of all is TTB, thrombocytopenic purpura, typical HUS, acute fatty liver of pregnancy, DIC, and the other causes, secondaries like drug, CAPS, or systemic lupus. This for the differential diagnosis with the broad spectrum, with the HELP, acute fatty liver of pregnancy, DIC, and atypical and TTB. And all of us know this table very good. You know the liver enzyme in HELP syndrome and the acute fatty liver is markedly elevated as we previously level, with high ammonia level, with the which is differentiating with acute fatty liver of pregnancy. So we excluded. When we go to the PTT and the PT and the coagulopathy, it is markedly with the DIC, so it is second to be excluded. It remains atypical HUS and the TTB. First, when you go to the complement 3, it is markedly consumed in the atypical HUS. It is normal in our case. And the Adam TS13, our Dr. Omara say in the previous case, with less than 10%, it is markedly in the TTB rather than the atypical HUS. And the management is the plasma infusion if the presence of sepsis and the plasma exchange, as we see, which is the common presentation or the common indication for the plasma exchange. Our management plan here is the blood transfusion with the 3 packed RBCs for anemia, antibiotic for the clindamycin plus the ceftazidime, controlling of the blood pressure with amlodipine 10 mg, methyl dopa 250 mg, 2 tablets 3 times daily, and the carvedilol twice daily 12.5. Hemodialysis every other day till it stops. And the use of the pulse steroids here, it is reported with good outcome in some literature. We give the 500 mg for the 3 successive days, and after exclusion of the active infection. And we started with 1 volume plasma exchange with the fresh frozen plasma, 6 weeks over 6 sessions, over the 2 weeks. And after the 2 weeks of the treatment, the hemoglobin improved and the LDH dropped, serum creatinine 1.7, urine output improved, controlled the blood pressure on the amlodipine 5 mg per day only, and the fair quality of life. Again, to continue or not, to do biopsy or not. After her platelet count reaching 800,000, we do the renal biopsy, and this is our renal biopsy with the picture compatible with healing stage of the TMA, with early secondary FSGS, with patchy injury and the mild acute interstitial nephritis, with the few neutrophil and the direct immunofluorescence for the fibrinogen, direct immunofluorescence for IgA, IgG, IgM, C3, and C1q was negative. And my take-home message here is the peripartum acute kidney injury anemia should always raise the possibility of the TMA. Early diagnosis and the management are necessary. And please, 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 as Dr. Amara say, don't hesitate to start the plasma exchange. If TTB is suspected on the clinical diagnosis, don't wait for renal biopsy.
Thank you, Professor Ahmed. Professor Riyad Saeed, unmute yourself, please. Unmute yourself.
Hello, مساء الخير. I think this is a fascinating case, and I agree 100% that the minute you suspect TTB, should start treatment. Now, if you don't have a facility for plasma exchange, please don't hesitate to use fresh frozen plasma infusion, 15 cc per kilogram body weight of a patient. Till you transfer your patient to a facility, you'll be able to do plasma exchange. That's really the golden standard. I think this case was managed in really proper way and in real time savings for the patient life.
Thanks, Professor Riyad, for your comment. And this is also the message, Dr. Riyad, in the treatment. Also, even in the presence of infection with suspicious of the TTP, you can give the plasma infusion until the infection is controlled, and you can start the plasma exchange. Thanks, Professor Riyad, for your comment.
So do you have a comment, Professor Rasha, please?
Just a comment that the patient had a history of preeclampsia in all previous pregnancies, which in turn raises the possibility of having another recurrence of preeclampsia in the current pregnancy. This should not leave us out from putting a diagnosis of thrombotic microangiopathy or non-placental thrombotic microangiopathy like TTP or HUS. I agree that the threshold for starting plasma exchange in such a case should be low, initiating on clinical suspicion, as our professors and colleagues said, and it should be applied daily until there is at least improvement of the platelets for more than what is written for more than 150,000 and for the LDH values to be near normal. The patient had hemorrhage, accidental hemorrhage, which will be toxemic accidental hemorrhage as a component presentation. And we should remember that both hemorrhage and infection can trigger TMA. So presence of hemorrhage, we should not only rely on diagnosis of pre-renal AKI or something like this, because hemorrhage itself can trigger or can precipitate development of thrombotic microangiopathy in pregnancy. As for kidney biopsy, the kidney biopsy indications, because the condition we're talking about it postpartum, follows the same indications for the general population, but it can safely be applied after 2 to 3 weeks after delivery.
Okay, thank you. A question from Dr. Farhan. Why not to start aspirin in this patient?
No. The aspirin is started because this is a high-risk pregnancy with previous preeclampsia. It started from the start. No, and she was in the aspirin during her pregnancy.
Was in the aspirin.
All patients at risk for preeclampsia should start the aspirin throughout pregnancy.
Yes, and thanks, Dr. Rasha, for your comment, because you explained that the risk for the thrombotic microangiopathy in these patients is the presence of the concealed accidental hemorrhage that is present in this case, and this forced pregnancy, and this leads to the deterioration. And also the previous preeclampsia is a very important risk factor for, as you mentioned, Dr. Rasha, in developing the thrombotic microangiopathy in this.
Dr. Ahmed Amar, a short comment, please.
Thank you, Dr. Yasser, and thank you, Dr. Ahmed Fayed again. Actually, sometimes we face a case like that, but only diagnosed with renal biopsy. They don't have the peripheral picture of TMA, only found in the kidney biopsy. We found TMA picture in the pathology. And we managed, like Dr. Ahmed mentioned, by empirical plasma exchange and the steroids. And actually, typically in this patient, we should send a test for complement abnormalities, either antibodies, autoantibodies, or genetic test. As sometimes in patients, they don't improve on plasma exchange and steroids, and most of these cases will have a complement abnormalities or genetic complement abnormalities that will need a complement inhibitors like eculizumab and ravulizumab and so on. And also if they pass to end stage, it will give us an insight whether to transplant them or not, and the need of complement inhibitor later on. It's in the past was not available, but I think now it's available in some centers to do this. Thank you.
The problem is not the availability, but Professor Rasha, is the complement eculizumab is allowed in pregnancy?
Yes, but it is not available in Egypt. This is a big problem, and the point Dr. Ahmed is discussing is a big dilemma. I just want to comment regarding the lack of the complete picture of microangiopathic hemolytic anemia in pregnancy or without pregnancy should not defer us from diagnosing or from starting treatment for TTP or thrombotic microangiopathy, because schistocyte itself, the presence of schistocyte is no longer required to diagnose microangiopathic hemolytic anemia. So we can diagnose based on clinical presentation, the presence of the anemia and the thrombocytopenia. Blood film lacking schistocyte should not defer us from diagnosing basically thrombotic microangiopathy and starting plasma exchange on a low threshold. As for the treatment and the eculizumab, yes, theoretically we should do start a plasma exchange empirically and then do a Dantas 13 level. If it is less than 10, we should continue plasma exchange with immune suppression and rituximab. If it is more than 10, then TTP is excluded and a typical HUS is more likely. In this case, eculizumab should be started and can be given as a prophylaxis for an indefinite duration.
Okay, thank you
Thanks,
for
Dr.
stressing this point, especially
Dr.
for the use
Yasser.
of eculizumab in pregnancy. تفضل يا
Okay, but for the renal limited TMA that Dr. Ahmed say, renal limited TMA or thrombotic microangiopathy, please don't forget that TMA is a pathological lesion. It is a pathological diagnosis that is observed in a wide spectrum of the disease, and it may be triggered by endothelial injury and or dysfunction, whatever for pregnancy or us, but it is a pathological lesion. So that's the renal limited TMA that Dr. Ahmed say it is a dilemma, big dilemma, that is we say, and also in the refractory case, as he say, Dr. Ahmed, with the treatment and Dr. Rasha comment. But I should insist it is a pathological diagnosis or the pathological lesion that observed in the wide spectrum of the disease.
Okay. Question from Dr. Rami Shahat, our coordinator, about how long do we need to wait to allow pregnancy after rituximab administration?
There are some schools that are now advocating the use of rituximab in some resistant cases during pregnancy. So we had discussion with Professor Pierre Ronco, he's the editor-in-chief of Kidney International recently, about a case of membranous nephropathy presenting during pregnancy and refractory to other lines of treatment, and he recommended rituximab. And there are some reports for published reports, I mean, using rituximab during pregnancy, and it showed efficacy of the drug and without significant adverse effects or complications. So rituximab can be used in pregnancy on some or based on some previous experiences.
Yes, Dr. Rasha, but yes, can be used, but be safely in the last trimester and the third trimester, because the fear for the fetal B cell aplasia that is maybe occur with for the neonates. And Dr. Rami, as I understand from, he asked when we can get pregnancy after the last dose of the rituximab. As I see and as I read, it more than the 12 months from the last dose of the rituximab dose, you can get another pregnancy for more than the 12 months that I read in some of the literature.
Yeah, agree on the theoretical adverse effect written on rituximab, but what I mean is a resort for patients who are refractory to other lines of treatment.
Yes. It can be used safely and according also to case by case, but be sure for the fetus, for the fear for the fetal B cell dysplasia, as I mentioned in the short introduction that I said. Sure, Dr. Rasha.
Yeah, agree.
Okay. Thank you, Professor Ahmed, for these very interesting cases, and Dr. Rasha for this.
Yes, I have two slides. I have two slides in less than 10 seconds. This is ICU, our ICU team in the internal medicine, and thanks because this is all the effort of all cases is done by this case, and also this is our acute nephrology team in the Qasr Al Aini, and thanks for our acute nephrology team and also the ICU team, and thank you.
Thank you so much.
Thank you so much. Thank you, Professor Ahmed, for these very interesting cases, and thank you, Professor Rasha, for giving us your great experience in this session about pregnancy-induced acute kidney injury. And excuse me to close this session. and meet you in next week إن شاء الله 9:30 p.m. when is coming Wednesday. Thank you. تصبحوا على خير والسلام عليكم ورحمة الله وبركاته.
عليكم السلام ورحمة الله.
السلام ورحمة الله.